Hey future doctors, thanks for joining me on Spoonful of Sugar, a podcast made for medical students by medical students to help the medicine go down. My name is Rhea Moherker. I'm currently a fourth-year radiation oncology resident in Pittsburgh, Pennsylvania, and I will be your host today. Welcome back to Spoonful of Sugar. In today's episode, what every medical student should know about ophthalmology, I'm very excited to have my friend from medical school, Dr. Will Foos, as a guest. Will and I actually graduated the same year from Drexel University College of Medicine. We graduated in 2020, and currently Will is a PGY4 ophthalmology resident. He is in his last year, will be graduating this summer, and is going to go on to do a fellowship in pediatric ophthalmology. He also actually has a super entertaining TikTok account called Ophthalmation, which those of you on TikTok should definitely check out for some fun ophtho and just medical related humor. Today's episode is structured a little bit differently than what we normally do here on the podcast. But last season, I recorded a similar episode called What Every Medical Student Should Know About Radiation Oncology, and I got really positive feedback. So I thought of starting to bring in some folks from other specialties as well to help all of us learn a little bit more about different niches within medicine, even if it's not an area that we're directly pursuing. The goal of this episode is really to introduce the basics of ophthalmology to anyone that might even peripherally interact with an ophthalmologist throughout their career. And at the very end, we will end with some career advice for those of you out there who might actually want to specialize in ophthalmology. I really do think, though, that no matter what field you go into, it's really valuable to get some perspective on what other doctors are, what their days are like, what kinds of things they're seeing, and any words of wisdom they may have about conditions that they see every single day. So with that short little introduction, let's get into the interview, and I hope you find this helpful. Hey, Will, how are you doing?
I'm doing great. How are you, Rhea?
I'm good, hanging in there. Well, I just wanted to say thank you so much for being back on the show. Just for our listeners, Will was actually the very first guest to host an episode on Spoonful of Sugar back in season 1. He hosted a handful of episodes on the anatomy and physiology of the eye, neuro-ophthalmology, and ocular pathology, which you guys should definitely check out if you're interested. And then now, as we're starting to get more into specialty-specific episodes on the podcast, I thought it was only fitting that I have him on as my first resident guest to tell you guys more about the field now that he's 4 years in. So Will, can you tell us a little bit about how you got interested in ophthalmology?
Yeah. So I think a lot of this kind of goes back to having my mom as sort of like a role model. She was an OBGYN. So my impression of medicine was always a doctor who did surgery in addition to medicine. And then I always really liked derm, kind of the Dr. Pimple Popper sort of stuff growing up. And then when I got to med school, I realized I really liked neurology as well. And as I was exploring different options, I felt like ophthalmology was the best combination of where the skin meets the brain. And I found, the surgical ratio was pretty great. There's a very, specialized knowledge set. And it's kind of a way to like specialize while still doing a little bit of everything. So that's why it was a perfect fit for me.
Awesome. And I hear you're going to be moving back to Philly for fellowship. So can you tell us a little bit about what kind of fellowship you're doing and why you chose that?
Yeah, I'm doing a pediatric ophthalmology fellowship. And I think kind of along the same lines as what I said, why I went into ophthalmology. I really like that the pediatric fellowship, you still kind of do a little bit of everything. Ophthalmology has a tendency to be very subspecialized. So pediatric ophthalmologists, their bread and butter kind of becomes, eye muscle surgery and strabismus, but they still do cataracts for kids. Some can still practice comprehensive ophthalmology, outpatient, and see kids as well. Some do glaucoma, they do some retina stuff, some mild oculoplastic stuff. So I think that's why I really liked it. Plus, kids are fun, and you get to see a lot of the weird stuff that you only really read about in textbooks.
That's super awesome. You're going to make a great pediatric ophthalmologist.
Thank
I
you.
think it's super cool that in addition to being an ophtho resident, you also have a pretty popular TikTok account sharing some medical knowledge. I follow you and your videos are always spot on and hilarious. Can you tell us like how that got started?
Yeah. So, I mean, I would say COVID and boredom. We graduated from medical school right as the pandemic started, and I went out to live with my parents for a couple months at the end of rotations, and I just had a lot of free time. So I started a non-medical TikTok account, and then I realized I kind of wanted to curate a different account that had more medical content. And then I just kind of thought of funny moments that were applicable, particularly in intern year, to how I thought about interactions in the with other providers or with patients, and sort of little movie quotes and stuff that would pop into my head that seemed relevant to those.
That's awesome. Yeah, everyone needs a little bit of medical humor to make the job a little less stressful.
Oh,
Um,
definitely.
what's your favorite part about the specialty you've chosen?
Ooh, that's really hard because I think so many of the individual components are really great. I think it's probably a tie between the continuity and relationships you get with patients, especially after you do a surgery that really impacts their quality of life. And then I think also just how sort of specialized the area is in terms of technology, and sort of a protected knowledge that a lot of other specialties don't really have access to. So you kind of become the go-to expert on the eye. Yeah.
Gotcha. Yeah. For me in medical school, the eye definitely scared me a lot. And it still scares me a lot. It freaks me out a little. And that's really why I wanted to do this episode. It's meant to kind of be like an education for all comers, and not just anyone that might be going into ophtho, but anyone that might peripherally interact with ophthalmologists in the course of their career. So I wanted to start off with just some very general questions about the field, kind of for everyone. And then for those medical students who are really interested in ophtho, I'll ask some kind of career advice type questions at the end. So first off, I was wondering if you can talk just a little bit about kind of the bread and butter of ophthalmology, and just like if there are general practitioners within the field and what their practices might look like.
Yeah. I would say general ophthalmology, usually we say, is comprehensive. There's a lot of subspecialty fellowships that will practice comprehensive in addition to their subspecialty. And also, depending on the subspecialty, the bread and butter does change. But for a comprehensive ophthalmologist, really the bread and butter are going to be cataracts, doing surgery and evaluating those. Additionally, you'll be doing sort of some basic screening and exams for diabetes, glaucoma, retinal problems. You can see dry eyes, some small eyelid procedures you might do, and some laser procedures. And of course, refractions, giving glasses. Ophthalmologists do that in addition to optometrists. We don't necessarily like to do it as much, but certainly that does kind of become part of the bread and butter. But in terms of the bread and butter surgery, it's going to be cataracts, and that's going to be a fair amount of what you see in clinic.
Gotcha. That's super helpful. And then you mentioned, you're going into pediatric ophthalmology, but what are some of the other kind of most common fellowships that there are to pursue in ophtho, and how long are those typically?
Yeah, most fellowships are about a year. Some of the more specialized surgical ones can be 2 years.
Mhm.
And then there's a couple that are, even a little more niche, even for ophthalmology. But the big ones are usually retina, which surgically would be a 2-year fellowship, but you can also do a 1-year medical retina fellowship. Glaucoma, cornea, oculoplastics, which is usually 2 years. There is refractive surgery, that's things like LASIK and PRK, or can also be specialized cataract surgery that's aiming to get people completely free of glasses. And then neuro-ophthalmology. Then there's pediatrics like myself, and then there's a couple more niche ones like ocular pathology, uveitis, ocular oncology, and even global ophthalmology.
Gotcha. That's super helpful. And I guess if you were to be like a general ophthalmologist, can you give a sense of what the general schedule might be like, and how most attendings split their time between clinic and the OR?
Yeah, so like you said, most of it is clinic. It's outpatient setting, unless you're in an academic program or you kind of you're with a group that takes call at a hospital. Usually, you're outpatient. Surgery will be 1 to 2 days per week. Usually, it might be a half day, and then you're in clinic the other days per week. Could be 3 to 4 days, sometimes half days. And then you might have those clinics kind of further subspecialized if you have a pre-op or a post-op clinic, depending upon how it runs, and maybe a day for lasers and minor procedures as well.
Gotcha. So it seems like a really good balance between like clinic and OR. And it seems like, I guess, can you give a sense of what the hours are like and how busy ophthalmologists are when on call and things like that?
Yeah. So, I mean, hours, it's going to, depend on the particular institution. It's very much like a 9 to 5 job in that sense. Most people will do probably 8 o'clock start for clinic, and then their last patient will probably be scheduled at 3:30, so they'll be done by 4:30. Some clinics start a little earlier, some start go a little later. Some clinicians like to have Saturday or Sunday, or like to have half days. Probably roughly the 40-hour work week now. Normally those are pretty packed. You're seeing a lot of patients. An average comprehensive ophthalmologist is probably seeing anywhere from 20 to 50 patients a day, depending on how busy they are. There are some retina doctors who see 35 to 70 patients a day. So it can be so I mean, when you're done, there's usually not much you have to do when you get home. If you're on call, depending on how the call is set up, oftentimes you can triage most ocular problems to the morning. And if you have a private practice, you can say, hey, we'll see you first thing in the morning. It's a little different for residency programs. And if the hospital has a consult service, you might be seeing them in the middle of the night. But for the most part, there's very few things that their definitive treatment can be put off till the next day usually.
Gotcha. So since you mentioned kind of the inpatient side and whether or not there's a consult service, how are the inpatients typically handled, and what are some of the most common inpatient consults you guys would see?
Yeah, I think I had this in here. So inpatients, I think, once again, it depends on where you're at. I'm kind of speaking from a residency perspective where, you're expected to cover inpatient consults and also in the emergency department. So probably a higher proportion of problems are coming from the emergency department because there's not a lot of things that patients tend to get admitted for. And, if someone were consulted on the floor, it's more kind of an acute change. A lot of the disease processes can kind of be grouped into things that are neurological, vascular, infectious, traumatic, or autoimmune in terms of what we're seeing. And most of the time, our initial evaluation is enough, and then we kind of give our recommendations for inpatient, and then we want them to follow up outpatient if there's a more definitive treatment there. There's a few exceptions with things we might go and see daily if it's something we had to do surgery on, if they had like a orbital cellulitis or some corneal ulcers, we need to see daily to make sure they're getting better. But for instance, typical consults we'll get disc edema consults, or people will say papilledema. There's a lot of different ways you can bleed in the eye, so often stuff like that. Vascular diseases, whether it's like an ocular ischemia, central retinal vein occlusion, artery occlusion, lots of strokes, infectious problems like orbital cellulitis, abscesses, corneal ulcers. lot of trauma in the emergency department, open globes, floor fractures, and then some uveitis. And then, amidst all this, we're going to get a lot of consults that end up being just dry eye problems.
Gotcha. Makes sense. Could be kind of a variety of things, it sounds like, and a variety of severity. This is a question that I'm like thinking of right now on the spot, but can you talk a little bit about what your exam is like? Like, let's say you're evaluating a inpatient and you're consulted for some trauma related to the eye, other than like what we all learn in medical school, like looking at pupils and extraocular movements. Can you talk just a little bit more about what you would be examining for and how you'd go about it?
Yeah, so I kind of have like an algorithm that I go through, and I think it's really good there's this resource called like timroot.com, and he kind of goes through this very well in a way that's digestible for a medical student. But I kind of start out with sort of vitals. For the eye, vitals are a little different than, blood pressure and stuff. So we'll check visual acuity. That's, reading the Snellen chart or a near card if we have that. We'll check the intraocular pressure, and then the pupils. Obviously, we'll look at that. We'll look at the extraocular motility and their visual field. That's usually the big 5 vitals that we look at first. And then if we have a slit lamp on hand, we'll do an anterior segmented exam, look at the cornea, sorry, I was getting a call. We'll look at the cornea, the iris, the pupil, the lids, the lashes, make sure there's nothing obviously wrong with that. And then we'll dilate the patient and we'll look at the fundus. So we'll look at the retina, we'll look at the optic nerve, the vessels, and all of that. And then if all of that doesn't really help us out, then we'll usually kind of ask for neurologic imaging or orbital imaging.
Gotcha. Thank you. That's super helpful. And what was that resource you mentioned that's good for medical students, the website?
Yeah, it's called timroot.com. He has this thing called OphthoBook, which you can buy if you like a physical copy, but it's actually free online, the PDF. And he explains things very well. It was kind of the Bible when I was doing away rotations.
Oh, awesome. That's super helpful for our students probably. So timroot.com, you said?
Yeah.
Cool. One question that I always have for like every specialty, because I know I have my pet peeves within my specialty, but do you ever get consults that you see and you feel like they probably weren't necessary, or you wish that they had been handled differently? Like you wish you got it earlier or later or not at all?
So most of the things are, not at all, because a lot of what we do is outpatient. So I think there are appropriate consults. I think whenever we can kind of divide ophthalmic complaints into 4 categories, one being, there's a problem with vision, the patient's seeing something or not seeing something that they should be. Then there's sensation, my eye hurts, it feels gritty, whatever. Then there's discharge. And then there's the WTF is that, which is, the eye just looks awful. It's popping out, they're not facing the same way. And I tend to take, complaints of vision if it's not just a generic, like, oh, my vision's blurry. But if a patient is, pretty adamant that their vision is changing and stuff, I usually take those pretty seriously. I think that's, a pretty appropriate consult. Same with the WTF is that category. If the eyes just don't look right, I think that's appropriate. I think a lot of, things that are like sensation-based eye pain are usually, it's usually dry eye, and especially in the inpatient setting, it's usually patients who are on respirators or they've been in the ICU with their eyes open the whole time, and it's just drying out, and that's really what it is. So I think it's really important for consults to establish the acuity of the problem, because once again, if it's a chronic problem, it can be managed outpatient. So we need to know, is this a new finding? And then my pet peeve consults that I will like die on a hill for are the papilledema consults and the fungal endophthalmitis consults. So for papilledema, this is the hill I'll die on. It's just the definition of papilledema means optic nerve swelling that is attributed to elevated intracranial pressure. So if you ask for a consult for papilledema, by definition, you are saying you are concerned about elevated intracranial pressure. So the eye exam can tell you if the nerve is swollen, but that has, the nerve can be swollen with elevated intracranial pressure. It can be swollen without an elevated intracranial pressure. It doesn't really provide much diagnostic use if you're already suspicious for that. Really, the best diagnostic thing is to get head imaging and to get a lumbar puncture. So most of the time, I find those consults like that I'm not really contributing much to the patient's care, and there might be some mild prognostic value, but it's not very diagnostic. And I feel like the people who put those consults don't quite understand that oftentimes. And then fungal endophthalmitis, just there's been some studies recently that if a patient is conscious and they can, tell you if they have visual symptoms, then and they don't have visual symptoms, it's less than a 1% chance that a fungemia will cause endophthalmitis. So that's usually pretty low yield. Obviously, that kind of breaks down for people in the ICU. Also, I really don't like uveitis rule-outs when a patient is asymptomatic also. And hallucinations are almost never an eye problem, so that is well. Yeah.
Interesting. Yeah, I'm sure by now you've kind of gotten it all in terms of the consults, but that is super helpful. So thank you for kind of sharing that. Is there anything that you see in the hospital sometimes that you're like, wow, I actually wish I had been consulted sooner about this? I know you mentioned like acute visual changes and things like that.
Yeah, I would say like acute visual changes. There's a few real, ocular emergencies. We all kind of hear about acute angle closure glaucoma, which is actually pretty rare, but certainly if it was legitimate, we would want to be there to intervene very soon because patients can lose vision very fast. And same with any patients with, retinal detachments or even an orbital compartment syndrome. Some patients, if they have trauma and bleeding behind their eye, it can lead to a compartment syndrome, and patients can lose vision very quickly if they don't have, emergent intervention with a canthotomy to release pressure. Certainly, that's something that emergency room providers should be trained to do, and same with trauma providers. So that's I definitely think ophthalmologists are more comfortable with it than they are, but oftentimes we're not in a place to come as emergently as is needed. So I think communicating how emergent that is, how high the suspicion is for an orbital compartment syndrome, if there's that, is really really important to preserve vision as best as possible.
Okay, gotcha. And so this is super outside of my wheelhouse now, and I'm sorry for my ignorance, but can you just educate us a little bit on like how orbital compartment syndrome would present and like what the red flag signs are that should be conveyed?
Yeah, so we're looking for the orbit is a compartment. You have the bony walls, and then you have the septum, which is sort of like a fascial plane on the front of the eye. And so you kind of have to cut the eyelids in that fascial plane anteriorly to relieve pressure. So in an orbital compartment syndrome, someone would have, bleeding or something creating pressure behind the eye that's pushing forward and choking off blood flow to the optic nerve and to the retina. So the way we assess it is, one, we're looking for, proptosis. The eye might be popping out, which is a, pretty obvious cause. And then the eyelids will be really tight. We check pressure, which is something, I don't expect every physician to be able to do, but certainly emergency room doctors should be able to check the eye pressure. If the pressure is really high and the eye is proptotic, that's a good sign that, and there's pressure on everything there. And then if you can't push the eye back into the socket, if you put some pressure on it and it's just hard, it's not, bouncing back, that's another sign. If the pupil is not reacting, if you shine a light, especially if you look at it compared to the other eye and you do a relative afferent pupillary defect. That's where, you move it to the eye that's not swollen and the pupil constricts, and then you move it to the eye that's swollen and the eye either dilates or doesn't constrict. That's a sign that, the optic nerve has been compromised. And certainly if they have vision loss with that, that's also, a very, bad sign. So kind of assessing all those together. And then there's, a lot of these patients will have CT scans, and you can see if any of those bones in the orbit are broken. That might be a good sign, because, there might be decreased pressure on the eye, but then you have to worry about other things. And then also you can see sometimes tenting of the globe, because everything's pushing it forward. The optic nerve is kind of pulling it back. So it doesn't look like a perfect sphere. It'll kind of be tented. You'll have a little triangle in the back of it. So those are all signs that, hey, this probably has an orbital compartment syndrome, and it's very emergent.
Gotcha. Well, that sounds terrifying, and thank you for teaching me about that. I'm hopeful that our emergency room colleagues are much better prepared than I to handle that type of a situation.
Yeah, I mean, it's not something you should ever be seeing on the floor. The only time you might see it is if a patient falls and they're on blood thinners and hits their head. But that's really about it. Yeah.
Gotcha. Well, thank you. This was all very helpful, and I feel like we've been able to give a good overview just for people that are interested in learning a little bit more about ophthalmology as a field, especially for first and second year students who probably don't have a lot of exposure to it. Is there anything else that you want to share that you wish every single medical student knew about ophthalmology?
Well, I think it has all the best parts of all the other subspecialties and specialties that I like, without any of the bad parts, in my opinion. And I know that it can seem very intimidating dealing with the eye, but it is something you gradually learn and become comfortable with the more you're around it. So kind of trust the process if it's something you think you might be interested in. And certainly, it's not all just cataracts and LASIK and, giving glasses prescriptions. If that wasn't really what drew me to it in the first place, I was more interested in the medical side of things, seeing how strokes impacted the eyes and such, and just, looking at the retina and seeing cool stuff like that. But even the stuff that initially seems, kind of bread and butter and maybe a little boring, cataracts, LASIK, glasses, glaucoma, as you get to know it more and more, it becomes more interesting, and you can dive really deep into pretty much any disease or anything in ophthalmology. It's pretty great.
Awesome, thank you. So just a couple of questions at the end for if anyone's sticking around listening who might actually be interested in going into ophtho. Can you just talk a little bit about the length of residency? I know you mentioned fellowship is typically 1 to 2 years, but if you can just talk about how long residency is and how common it is to do fellowship and how hard it is and things like that.
Yeah, residency is, you do 1 year of internship. Now all the programs are pretty much integrated, so wherever you match for ophthalmology is where you'll do your internship. Each program has their internship set up a little different. It might be 3 to 6 months of ophthalmology during that. Some are more surgical, some are more medical. And then after that 1 year, you do 3 years of residency. And then you don't have to do fellowship. Certainly there's a very high demand for comprehensive ophthalmologists everywhere. But some people like to, if they want to develop, certain skill sets, be able to do retina surgery or corneal transplants or something like that. And certainly it does make you more marketable for more competitive markets, like in cities and stuff, or if you want to do academics. And certainly, there are some fellowships that are pretty competitive, like oculoplastics and surgical retina, but a lot of other ones, at that kind of cutoff, it's not too competitive, and a lot of people get a pretty good choice in terms of where they want to go in terms of that.
Gotcha. And if I recall, for residency, ophtho is a separate match than the NRMP match, right?
Yeah. So same with the fellowship match. It's through the San Francisco match.
Mm-hmm.
So that's how you go about it, and it's the same San Francisco match for fellowship as well. And I think it starts a little bit earlier too. I think it becomes live either July, August, and actually I think next week is when they announce the first week of February currently. But yeah, next week is when they announce the match. So good luck to people who are matching.
Gotcha. Yeah, good luck. I remember that in med school, like all the ophtho people found out before. I think urology does a different match as well, where they find out a little bit earlier. But that's good to know that the application process starts earlier as well in the summer. Um, do you have any advice for students who are potentially thinking about going into ophtho?
Yeah. So, I mean, I can say with like pretty much every subspecialty that, if you find yourself torn between a couple, like why ophthalmology has like the best part of that. So, I mean, like I just kind of wrote down a couple of them when I was looking at your questions beforehand, but like for peds, you can still see kids. For neuro, most of the brain actually goes to the processing vision and, motor function for the eyes. Surgery, you get to do surgery and you don't have to do a surgical residency that's super long and grueling. You don't have to live in the hospital, and you can, sit down for your surgeries. You still get all the gross skin stuff on the eyelids and stuff that you like in derm. Radiology, we have our own imaging. We have like OCTs that can image the retina really well, and angiography for that. And you also get really good with maxillofacial imaging. For you, liking oncology and doing radiation oncology, there's lots of ocular cancer as a subspecialty, and we get to play with lasers a lot too. They're not all for cancer, but the lasers are very fun. Anesthesia, you get to do blocks without having to memorize all the pharmacology. Like most of our pharmacology is summed up in if you remember like the color of the bottle caps, like exactly what they do and exactly what medication the patient is talking about. You'll spend a lot of time in the ER if you do a residency. So if you like ER, there's that. Like OBGYN, I was saying it's surgical and medical. You don't get too messy with bodily fluids. Not too many emergencies. There's lots of entrepreneurship opportunities because there's a lot of technology in this, and pharmacologic research in the space that's going around, and even in imaging. Lots of demand and flexibility. And ophthalmologists generally are pretty nice because they have a good work-life balance with everything, and you get really good continuity of care with patients and have a meaningful impact on their quality of life. And most of the time, you don't have to deal with them dying as much either. So I think that's all really, really some of the great things about ophthalmology. The one thing that kind of is a little bit of a bummer is because it's kind of so specialized, it's a little isolated from, other specialties, especially when you're out practicing. So, but, you can make the effort to see your friends in the hospital as well, and in their other specialties and such. So, yeah.
Yeah, that's awesome. I personally like to hang out with my friends outside of the hospital more.
Yeah.
But yeah, that sounds awesome. I think like Radonc, Ophtho sounds like it's really the best of both worlds when it comes to like medicine and surgery, which is kind of the big decision that students have to make. For any students that are potentially going to do an away rotation in ophthalmology or just a dedicated ophtho rotation, do you have any specific advice in terms of how to prepare for the rotation?
The Tim Root book that I talked about earlier,
Okay.
I think if you read that like cover to cover, that's really great. I think, when you're a med student, there's not a ton you can do in terms of like physical exams and, to contribute to patient care. So I think, genuine interest really goes a long way. Certainly if we have a lot of applicants who have been, techs beforehand, or, if they've had their home rotation first and, you got some experience in terms of taking eye pressure and stuff. I think that definitely, if you are able to make yourself useful, that's really helpful. But certainly we don't necessarily expect med students to do that. And then I think, it's a really small field. I think after a certain point, when we were applying, there's a big emphasis placed on step one scores and, research and stuff. And while it is very important to do well on those, and I think after a certain point, there is a diminishing return in terms of how many research publications you do or whatever step score you get. I think at that level, it's about the connections you make. And so you want to kind of gear your ways towards, places where you think you can make a good connection and make a good impression. And certainly, geography, demonstrating interest in a geographic location is, very, very important, because that will, determine how your interviews go. Yeah.
Awesome. Yeah. And I totally agree with that from my experience working with med students. I think just showing genuine interest and interest in connecting with people and interest in the field, that goes a really, really long way. Well, thank you so much, Will. This was all super helpful. I think our med students will really appreciate it. And just thanks for taking the time to share some of your advice.
My pleasure. It's great to see you again, Rhea.